the collection has to be accurate. And that would give you a good marker. Serum creatinine, however, is a good marker if you know the limitations. And the limitations are that one really has to lose a lot of renal function before the serum creatinine goes up. So I tell people that, if I donate my kidney with somebody from SIUT, so if you donate one kidney, your creatinine remains normal. Theoretically, you've lost 50% of your GFR, although the other kidney compensates, but huge losses of GFR are not reflected, early losses of GFR are not reflected in creatinine. And this diagram is interesting to see. If you can, So if this is the serum creatinine, and this here, and if this is your GFR, so an excellent GFR would give you an excellent creatinine. That is what you would expect. But if you look at this, you will have to lose a lot of GFR or a lot of renal function before your serum creatinine actually rises. And what I did was to add this. If you look at this red dot, this is 1.5. This is representing a serum creatinine of approximately 1.5, and it could actually mean a GFR of 80%, or a serum creatinine of 1.5 can actually represent a GFR of only 40 or 35%. So serum creatinine is a good marker once it's abnormal. So once it's being more than 1.5, then the rise is equal to your GFR. But before that, it's not a very good marker for renal function estimation. So it's important if you're suspecting renal dysfunction, not to go just by the serum creatinine, because what the serum creatinine, the GFR depends on is the serum creatinine and the degree of muscle mass that we all have and the age that we are at. And so there are now many other factors by which you can estimate a GFR, which is an eGFR, which takes into account your age, your muscle mass, your body weight, and so on and so forth, so that this figure, which can be so varied, becomes relatively more accurate. As we just talked before this meeting, ultrasound unfortunately doesn't give you any idea of renal function. It just tells you what the kidney looks like. And sometimes bad-looking kidneys may have bad function, but that doesn't really mean anything. So for the test summary, I think we'll just say that there are many tests that can evaluate renal function. Early proteinuria is a good indicator of renal functional changes, and serum creatinine, even small changes in serum creatinine, from being abnormal, from being normal to slightly abnormal, represents huge loss of GFR. So once you have 3 and above, it hardly matters. But if you are from absolutely normal to 1.3, it really matters because you're losing about 70% of your GFR at that time. So from rheumatological point of view, where our paths meet, apart from the diseases, it meets much more because of the drugs that we all use, and especially the rheumatology uses in relation. And we'll talk about the most commonly used drugs and how they affect the kidney. And the most commonly used drugs, not only by rheumatology but worldwide, would probably be non-steroidal anti-inflammatories. All these drugs have something to do with interference of the prostaglandins, and because of the prostaglandins, they alter the medullary blood flow, and then they alter the salt and balance. So we all know that non-steroidal anti-inflammatories can cause fluid retention, salt retention. They all interfere with antihypertensives when people have higher blood pressure. And unfortunately, over a period of time, sometimes they can cause other things like inflammation or interstitial nephritis associated with long-term use and with concomitant use of other medications, especially with ACE inhibitors. And they have a major role when somebody is hypertensive or is elderly or when they are in volume loss, then the prostaglandins are mainly required. So renal prostaglandins are mainly associated, they have an effect in relaxing smooth muscles. They lead to reduction in vascular reactivity and protect the vessels from catecholamines, angiotensin, and renin, the hypovolemic state. And it also reduces plasma endothelin 1 concentration. They are both cortical and medullary prostaglandins, and both have have rhinoprotective effects, especially in states where you get dehydrated. So if somebody is using prostaglandins, is elderly, is an antihypertensive, gets dehydrated, then this combination becomes not lethal, but really affects the kidneys strongly. And this is just a pictorial figure of how these prostaglandin effects, both for in the glomerulus and volume depletion, how they antagonize the effects of these things. Inhibition of the prostaglandin synthesis with NSAID it usually leads to a reversible ischemia and decline in glomerular capillary hydrostatic pressure. Plasma constant creatinine tends to rise, but tends to rise within the first 3 to 7 days because this is the time required for a steady state to be achieved. The other thing that happens is what we call is tubulointerstitial nephritis. The interstitium, or the initially thought to be the non-functional part of the kidney, the non-glomerulus part of the kidney, which is the intervening part, it causes a tubulointerstitial nephritis, and these are the most common etiologies are drugs, infections, and other medications that we use. And the most common medications that they tend to cause them are antibiotics and non-steroidal anti-inflammatory. There are other drugs that we all use commonly are allopurinol, which also does this, and proton pump inhibitors that we use quite often when we are giving people a lot of non-steroidal anti-inflammatories. So it is a disease which causes inflammatory cells to appear within the interstitium, which causes tubular damage. It tends to leak some proteins, usually not nephrotic range, but sometimes in the nephrotic range, and they causes damage to the tubules and causes renal functional impairment. The other drugs that I'm presuming that rheumatologists also use for modulation is cyclosporin, especially for